Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you will find this program very informative, with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
There are many different types of neurological conditions. Neurology and the field of neurosciences is the specialty dedicated to the diagnosis and the treatment of issues affecting the nervous system, and that includes the brain, the cervical spine, peripheral nerves, and muscles. Epilepsy is also a big part of what we're going to be discussing here this evening. During the next hour, we have experts focusing on and answering questions about pediatric neurosciences in the borderland. This evening's program is underwritten by the El Paso Children's Hospital, and we also want to thank the El Paso County Medical Society for bringing this program to you since 1997. I'm Catherine Berg, and you're tuned into the El Paso Physician. Thank you so much for joining me this evening. Tonight, we're going to be talking about pediatric neurosciences in the borderland, and we have a veteran with us who's been in El Paso for a whopping a little bit more than 2 years, but he's been on the show before, and this is Ziyad Makoshi, and we're going to ask you about what your favorite Mexican food restaurant is here in town. You are the medical director of pediatric neurosurgery at El Paso Children's Hospital, and you brought your friend. She says she doesn't have any friends, but I know she does. You brought your friend, and she is Dr. Alexandria Melendez-Zaidi. Did I say it right? Zaidi. There you go. And she's a board-certified pediatric neurologist and an epileptologist at El Paso Children's Hospital, also with Texas Tech physicians. So Dr. Alexandria, we call her Allie, I understand, Melendez. You've been in El Paso most of your life. You're a Thunderbird, Coronado High School. Yes. And I said, just to kind of lighten the mood a little bit, number one, we had to ask where you went to high school, because that's the El Paso question. And number two, what is your favorite native Mexican food restaurant in town? This is like a plug. We shouldn't say this, actually. You know what? Never mind. We'll talk about that after the show.
Ooh, the type of like taco?
Yeah. Is it rellenos? Is it enchiladas? What is it?
I like machaca.
Really? Oh, I have the place for
good,
that.
Right?
Okay. I'll be quiet again, because we try not to give plugs.
Yeah. I have a place, but
I have a plate. We'll talk about that after the show. Okay, Makoshi, how about you?
I was thinking classic with the tacos, actually.
Oh, with the tacos. Very nice. Beef, potato? No,
Beef,
you don't have to go there.
Yeah.
All of the above. So, Makoshi, let's talk about you. So, again, you're a medical director of pediatric neurosurgery at El Paso Children's. What does that mean for people who are tuning in? And again, you're not a neurosurgeon, but you are. What does that mean to the general public?
So the pediatric neurosurgery is one of the specialties that we don't have enough in North America. So they're few and far in between. There are sometimes in major centers where you'll have 2 or 3 pediatric neurosurgeons, but then similar to El Paso, the closest centers may be as far as an 8-10 hour drive. So pediatric neurosurgery is a subspecialty to manage any of the pathologies that involve the brain, the skull, or the spinal cord, and even the peripheral nerves. So we've had a lot of kids that were born with abnormalities that developed in utero, like open spinal cords that need immediate surgery, a lot of water on the brain, hydrocephalus, the big heads that sometimes need shunts in order to live normal lives. And these kids were transferred before to other centers that were far away. So it was travel for family, a lot of expenses, not a lot of as far as support. So bringing that here where we can manage those conditions and growing the neurosurgery program has been one of my jobs as medical director, to continue to offer what we can for El Paso and the surrounding region, and keeping those kids from having to travel with their families a far distance to get treatment and follow-up.
Which is so important, because we talk often on this program about the support system. And when, especially as a child, when they leave their surroundings, it's very difficult for them to get their bearings, so to speak.
Yeah.
Thank you for being here, number one. Dr. Melendez, let's talk about you. Again, board certified in pediatric neurology and also an epileptologist, which is just fun to say. Not that I practice it all the way over here.
Yeah.
But in the world of epilepsy, and I think we talked about this several years back, there was always a child or two in elementary school as we were growing up, and we all knew that if there was some kind of a seizure happening, that we would get out of the way, make sure that maybe they were turned on their side. So there's these trainings that we went through when we were kids. Bring that into what it is that you do all day, every day. And what is epilepsy? And what is the cause? Children, do they grow out of it? Which is something else that was an issue way back when. But maybe talk about what you do all day, every day.
So I can, maybe I'll talk about epilepsy first.
Okay, sure.
So epilepsy is kind of a fancy way of saying someone who's predisposed to have lots of seizures or a few seizures. So like any one of us could have a seizure, if you got hit in the head hard enough, if you had an electrolyte imbalance, with your chemistries in your body, anyone could have a seizure. But someone who has epilepsy is someone who has what we would call unprovoked seizures, meaning that they just kind of happen out of nowhere. So generally we say that if you have more than two or more unprovoked seizures, you have epilepsy. If you have one unprovoked seizure and like a very abnormal kind of electroencephalogram or EEG, which looks at your brain waves, then that would be another a definition of epilepsy. And epilepsy tends to be more common in kids. There's probably a ton of like basic science reasons as to why, but for that reason, even like general child neurologists end up seeing a lot of epilepsy. So training in epilepsy just gives you a little bit more experience, I would say, managing the kind of like plethora of like different epilepsies that there are, understanding how to read and interpret EEGs, understanding the kind of role of surgery in epilepsy care.
So on that note, when I think of, and maybe we can look at the first seizure, whatever that seizure looks like. I know it's different with every child. You said there are different types of epilepsy. When you're looking at children, is there a specific age or a roundabout age when this starts happening to someone who will be a child that has epilepsy, and again, different types, but...
Yeah.
And how do they know what to look for?
So the kind of scary thing is, epilepsy can start at any time in childhood because it happens for all different reasons. So one of the most common causes is like a structural epilepsy. So that can be from a genetic disease, meaning, you're born with something and that genetic disease changes the structure of your brain and predisposes you to epilepsy. On a kind of similar note, in the structural epilepsy category, some kiddos have a very like rough time during birth and either have some degree of injury, maybe like a hypoxic, we would call ischemic injury, that can cause structural problems as well as others, and that can predispose them to epilepsy. That would be more like the kind of neonatal period, less than 28 days. And then there's many other causes of epilepsy, and those are the ones that tend to present later on in childhood. Those are your what we call kind of idiopathic epilepsies, meaning we don't have a cause for them. The kiddos have a normal MRI. We maybe do genetic testing. The genetic testing is negative, and those can kind of go one way or the other in terms of petering out and not having epilepsy after several years, or some, rarely will go on to continue to have it in adolescence and adulthood.
And so seizures, and I'm somewhat familiar with them. My grandmother had seizures, and it wasn't at all what I expected a seizure to look like, which is why I was asking what it is that a parent can look for, especially in a brand new born, an infant. Because you think of seizures and somebody's moving around, or there are other seizures where there's absolutely just stiffness, which is what my grandmothers were. And I thought, what's happening? I had no idea what was happening. And so for the sake of the audience, in trying to describe what they can present as, so that we kind of know, well, what happened? Well, they had, 2 or 3 seconds where things just went wild, and then we don't know what happened. So if you can describe them, and I know they're very different with every person, I get that. Maybe give us a little bit of help there.
So, yeah, you're absolutely right. Actually, the International League Against Epilepsy, the ILAE, has a huge list of the different types of seizures that you can have that range from kind of strange ones that are called gelastic seizures. So those are like laughing seizures to, kind of your more typical ones like you see on TV where you have like kind of stiffening and rhythmic movements. That's called like the tonic-clonic seizures. So those are probably these tonic-clonic seizures, GTCs for short, are probably the most kind of common and like classical ones that you would see on TV or in movies. Those are quite common. Other things that can look like seizure, as you said, kind of like a forced stiffening. And then there are many seizures that just kind of look like a absence of awareness or loss of consciousness, not necessarily any changes in what the person is doing motor-wise, but maybe they're, they just stop responding to you, or they're staring off in space, or they all of a sudden lose their ability to talk kind of reasonably and start kind of saying the same thing over and over again. So I would say that
it's all over the place.
It's really all over the place.
My son calls them zappies. It's kind of like you just have a little bit, and it lasts just a couple of seconds, but he completely loses all awareness, falls down, has hit the shower, has hit the, it can be something that lasts a couple of secones.
It can.
Versus a couple of minutes.
It can last a few seconds, a few minutes. Most seizures last less than 2 minutes, but there are, the more rare cases where they can last long. They can last 5 minutes or longer. In those circumstances, that's when, we start to get like worried.
And now we're going to bring you in there, Mr. Canada Man. Sorry, we have these fun things before the show starts to get everybody a little bit loose and have fun. So when there needs to be intervention, again, neurosurgeon, I don't know how to ask this question exactly. So when is it that Dr. Melendez has a concern enough to where it's now time to see what the interventions are going to be? And maybe we can start there without going into surgery first. What can some of the interventions be with, again, and I know we talked about different types of seizures, but what types of seizures belong to what interventions? And then maybe we'll go into surgeries after that.
Yeah, no, that's a great question. So what we look at is having a proper workup, and that's where kind of both of us will get involved. Originally, they'll see as far as they should see a specialist because you need to get the appropriate diagnosis. Is this epilepsy? If it is epilepsy, are they being appropriately treated with the right medications or not? If it's not this medication, that's a good response. Do they need another? So that original workup will start usually with Dr. Melendez. Beyond that, we start to look at people that are either refractory, where they're still having seizures despite the medications, and medications aren't enough. They're not tolerating the medications, or they've tried multiple medications, but the seizures are still debilitating. They're affecting their quality of life. So then we talk about other alternatives, and those can be surgical, where we're not treating the brain itself, although sometimes if we have during the areas that are triggering a seizure, we can actually put something in to almost depolarize the brain, kind of disrupt those pathways to stop the seizure. Other things like vagus nerve stimulators. So those are kind of little battery driven with the big nerve in the neck, and that helps a lot of kids, maybe not completely go into remission, but decrease the severity and the frequency of the seizures, which can make a huge difference for some kids that are seizing up to 50, 100, some even 150 times a day, just many seizures throughout. They can't even leave the house, which makes a big difference. The other part of it is where during the workup to find out why they're having seizures, is there something in the brain? Is there, for example, a tumor? Is there a bleed? Is there an old injury? So is there some cause where we could target that with surgery to take it out and have a good response if that's where the seizures are coming from? So it's a detailed workup, involves multiple different people, not only us, but also getting as far as a neuropsychiatric testing, getting as far as something called functional MRIs, where we actually, for kids that are able to cooperate, doing tasks where we look at their brains and seeing what parts of the brain light up. So all those are useful information to localize, well, this is where their speech area is, this is where their memory area is, this is where the seizure might be coming from, it's affected this or affected that. So it's not a simple thing when they come to see us. We put them through a battery of workup in order to give them the best recommendations to get a better quality of life. That's the hope at the end of this, is to get their seizures, if not cured, at least better controlled so that they can live a better life afterwards.
So here's almost a question that I should have asked prior to that. So to diagnose to diagnose physiologically in the brain what is happening, what are those tests that you're looking at? You were talking about MRIs. You were talking about different ways of taking pictures in the brain, but also, and I remember now, we talked about, the TV shows that you see, and there's operations, and the person's talking, and there's a doctor behind him operating on the brain. That sticks in my head. So we're going to talk about that again, just in case people didn't watch the show last time. That fascinates me. That absolutely fascinates me. But to diagnose what type of seizures are occurring, the zappies versus full-on epilepsy, 2 to 5 minutes, how is that done? I mean, I know there's the clinical way of watching, listening to what maybe people around them have witnessed, because the person having the seizures often cannot tell you, correct? How, and I'm throwing that to either one of you who wants to take that. Dr. Melendez, there you go. How does one really find out what type of seizures are going on?
Yeah, so
it's hard. I know.
It's hard. So yeah, you're right. Often we kind of listen to what we'd say the clinical history is, like what the patient looked like, what the parents saw, sometimes what the patient felt, because with some types of seizures, there's very kind of characteristic, what we'd call like an aura, like, oh, I feel like something rising in my stomach, like some nausea, or I hear something, or, there's these different little kind of symptoms. So we take a very, I would say, thorough history of what the clinical seizure looked like. And then often, we'll then get this, the brainwave test, so the electroencephalogram or the EEG, where they basically kind of put special stickers all over your head, and then you're able to look at the kind of baseline brain activity. Not all the time, but often patients who have epilepsy will have some kind of subtle or very obvious, in some cases, abnormalities on their EEG that point us in the direction of, okay, this really is epilepsy. What are those things? Those are abnormal activity that we call kind of like spikes or sharps. The analogy that we often give is, if a seizure is the fire, then what you're seeing on the EEG are the sparks. So yeah. So it's evidence that something is building, or something could build or has been there. The EEG ranges from, often it's like a routine, it's like an hour-long study, and most of the time that's sufficient to get the information, particularly if the kiddo, you get them to go to sleep. But sometimes we do have to do longer studies, and I would say those are generally necessary in like a surgical patient that you're wondering, is this epilepsy coming from one part of the brain in particular that Dr. Makoshi can remove?
So even if they're not having a seizure episode, the tests are still able to see how the brain is functioning. So someone does not need to be in, and I know you said sometimes it's 150 episodes a day, but say it's someone who has 3 a day, and they're in for that hour, you can still kind of see where the misfirings will be, or whatever the wording would be in that case.
Yes. Okay. There definitely is that possibility.
Okay.
When we're doing the surgical workup, as part of that workup, one of the things that we aim to do is actually capture someone, we say, on EEG as they're having a seizure. So we see exactly, which part of the brain is it coming from, or is it coming from kind of all of the brain at the same time, knowing if it's focal, meaning it's coming from here or here, versus generalized, meaning it's coming from kind of everywhere at the same time, is very important, because it tells us basically whether someone's a surgical candidate, what type of surgery may be offered, because you can offer surgery to either, and even backtracking also what type of medication would be best for that patient.
That's a perfect segue, because that's my next question. I know surgery's down the line, but I feel like with a lot of these programs, we wait to see what the other interventions are. So we talked about refractory means the seizures are still happening even on medication. And seizure prevention medication, and I know there's a lot out there. When and how and what is it that we are giving to individuals? Does it depend on the age? Does it depend on the severity? I think dosages are like that, but I don't know if there are a lot out there. We don't have to say the names of them, but just in general, when someone is relatively diagnosed with having seizures, what is the next step from there? And again, I'm throwing that out. Dr. Melendez, when we talk about cutting into the brain,
people on. You put people.
I will tell you,
out with the cutting.
I'm going to put him on the hot seat a little bit because we're going to make a TV show out of him. Not that we aren't already. But as far as the medications go, treatments in general, how do you start? And do you tweak that as time goes by?
Yeah, absolutely. To the latter question about tweaking it. So you choose medications based on a lot of things, based on age range, where you're treating the seizures, based on the type of seizure, whether you think it's focal or generalized. I'll give you an example of both. So, there's a lot of literature, very kind of famous literature that shows that in like neonates, for instance, we use a really old school drug called phenobarbital, which has been around for over 100 years. It might be exactly 100 years. Not a very nice medication, to be honest with you. Lots of side effects. It is very, very sedating, but it's unequivocally the best for that age range.
See, okay. And tell me the age range again.
That's typically like neonatal seizures.
Okay, so
like,
young.
Yeah, like kiddos who unfortunately experience them around birth.
Okay.
And then there's a slew of other medications that we have to offer. And again, there's some that are better for focal seizures. There are some that are better for generalized seizures. There are some that are more kind of powerful medications that are good as we move like into that refractory epilepsy category. As kiddos are moving through all the typical ones, and we're needing something that's a little bit more powerful. All of those tend to have, as you might imagine, like worse side effects or more scary side effects potentially.
Okay.
So there's a lot to choose from, and then there's also kind of specialized medications for certain seizure types, like very very special ones. So like patients who have tuberous sclerosis complex, which is a genetic disease, and seizures because of that, they should get vigabatrin. Patients who have infantile spasms, which is another kind of infantile epilepsy, they should get some type of steroid generally. So
I'm hearing when you said tubular, did I say that right? Sclerosis, there's some kind of scarring in areas of the brain. Am I understanding that correctly?
That's a very interesting disease where it's actually they're called tubers that grow, and they're almost like benign tumors that kind of grow everywhere in the body. There's potentially, but I would say like the most burdensome kind of aspect is that they grow in the brain, and they're very epileptogenic, so they have a very high potential to cause seizures. Yeah.
Okay. That's a good transition too now into brain tumors, which is, I know, a specialty that you're, it's like, yes,
yeah.
It is now my turn.
Yeah, don't talk to me.
So let's talk about brain tumors. And again, just to say the words brain tumor, is scary, but there are some, and I remember us talking about it last time, that there are some that are not so scary, you can take care of them, and there's others that are pretty dang scary. Talk about the gamut for us.
I mean, brain tumors, anytime you're talking to any parent, we're paralyzed with fear.
Oh, of course, you just hear the words like, what?
So it's important when we go through it is that you want to be confident that you're going to be treated the best possible treatment for your child with the best possible outcome, and that's what we aim for. It's hard to say that all tumors are going to have fantastic outcomes, but we can aim for the majority because we try and diagnose them early to catch the symptoms, get the appropriate imaging to know exactly where the tumor is and what type it is even before we offer surgery, and then discuss with the family so that they're prepared to know, well, this is what we think it is, this is what we can do to remove it safely so that your child recovers from this. Sometimes they can end up being cancerous tumors that need other types of treatment. So the mainstay of treatment is to remove all of it, to do the best we can at the beginning. And some will need, as far as chemotherapy, and if they're a bit older, radiation. Other tumors are more not as cancerous or benign, where if we take it all out, then it's a cure. So once we've done that well, and people are very scared of brain surgery, if you're going to operate on my child's brain, are they going to be the same? We always try and go in, and it's hard to, we never can make promises to say that we're always going to be 100% fantastic, but generally in pediatric neurosurgery, when we're going to operate on someone that's coming in well, the aim is that your child comes out of the surgery the same or better. And that's the main idea, is that we've removed the tumor without hurting your child so that they can live the rest of their life and do fantastic. So the majority of our kids are going back to school, going back to living their lives. You wouldn't even know that they had brain surgery. So it is scary. It's going to be scary to anyone. But it's important to know that the best treatment is available, and that's what we're going to offer with everything that we can, from the best modalities of imaging, from intraoperative monitoring, where we have a whole team.
Intraoperative monitoring.
So we actually, as far as monitor the function of the brain around the tumor to make sure we don't go through any areas that may cause injury to the brain.
Is that segue I've been looking for?
Sure.
Okay, there it is. Because when the person is child, and I guess this is also age related too, if somebody's able to communicate with you what is happening. So when you say being able to know what the functioning of the brain is as you're operating, talk about that, because that, again, it almost seems sci-fi. And I know I've seen TV shows, I've seen movies, but talk about that in a realistic format so that we can know, okay, the arm's moving. Can you speak? Can you say this word correctly, etc.? Can you hear this? Can you, what have you? Take that a little bit, and I'm joking about it. And it's really no joking matter, and I completely respect that. But again, it's fascinating to me because your brain operates your little toe. How often do we connect those two things? But we do. It matters.
True.
So I'm gonna let you take that anywhere you'd like to take it.
So
thank you for laughing. I like you. And you were worried about this, right? See, we're having a good time already.
I'm just amused.
And it's an important question, is that, and I'll go back to where parents are always afraid of brain surgery because they're afraid of what you don't know, which makes sense. And that's where I come in to explain it, that no, the whole idea of doing surgery is to do it safely, not to injure anything, so that your child comes out walking, running, playing, going back to living their lives. So there's a few ways to do that. Sometimes in older kids, when they get to teenage years, and definitely in adults, if it's in an area that's next to the area that controls speech or movement, we can do awake surgeries. It sounds scary, but actually patients do quite well. We'll play music in the background for them. They can sing along if they want to. They wake up, and then we actually stimulate with little electrical pulses around the tumor to find out, all right, this area controls speech. Different areas can control different things. This area is English, this area is Spanish. So it's even more complicated than that. This area names objects, this area names animals. So it gets very detailed, in fact, what you can do with awake surgery.
Wow,
so it's rather fascinating. And that keeps us safe to know you're going to leave this surgery removing as much of the tumor, if not all of it, while safely preserving that function. And that's for older people that can tolerate being awake. Kids, I don't have that luxury sometimes when they're too young. So we have other correlates where we have our monitoring and we actually stimulate the same area of the brain, and on a monitor, we can see if we've as far as stimulated their hand or their leg.
Interesting.
And that gives us that feedback that we're very close to that.
Now, on the monitoring, are you seeing that in the brain, or are you seeing that physiologically with their hand or foot?
We form a circuit. So we stimulate here, and you have as far as little needles that are sitting in the muscles and the nerves. So if we stimulate here, naturally that fiber goes all the way down to, as you said, your little toe, and you get that little bit of movement, and they see it on the monitor. So we know that's the area that controls it, and we can stay away from that. So there's a lot of things that keep us safe. And that's what, taking away the scary to say, no, we have these abilities to do this safely. And that's the main goal, is to do these surgeries safely, to give the best outcome for the kids, to go back and live their lives the way they should.
Right, exactly. So when we're looking at, I know we're looking at brain tumors and all kinds of other neurological issues. We're looking at brain vascular malformations too. I know we're talking about the tumors, but when we're looking at vascular issues, because you've got a lot of threading up in there. Talk about some of these malformations. Are these usually something that is congenital, something that people are born with? Is it something that's developed over time? How would you define a vascular malformation in the brain?
So vascular malformations for the brain are anything that involves blood vessels or blood. So there are a few congenital, and we see a lot more of them here in El Paso than we do in other regions, because there are some genetics for little pools of blood called cavernomas that have a gene associated more commonly in Hispanics than otherwise. So there's a mutation that can run in families. So I get a reasonable number of patients that are coming through that have multiple of these small little areas of blood. Doesn't mean that they're going to have any symptoms, but that's a discussion that we have to have with the family. Some of them can cause bleeding repetitively and need to come out because they can cause symptoms, they can cause seizures, and those are the ones we aim for. Others we just watch and they behave themselves.
How do you know to look for them? So is this something where an episode must have had happened for you to say, okay, we need to look at this?
Usually that's how it comes to
Okay.
be. Either they've had a sudden headache, either they've had a new seizure, either because if it's big enough, it's caused a problem with speech or movement, and then they get a scan. Some of them are incidental, where they're playing sports, they fall, they get a scan, and you see them.
Huh.
Or they're getting scanned for a different reason. So both of them are a possibility, and I've seen both come through the clinic.
Goodness gracious. Okay, so now we're at this point, and you see, let's just say somebody fell down, they had a concussion, and you're looking at the image, and the image does show these different pools in there. Now there's a discussion with the family.
What is that discussion?
What is that discussion exactly?
And that's where, as far as we need the family to understand that there could be a genetic component, and testing for genetics to know also the risk for the rest of the family. Because it's important to know if there's something that's going to run the family. Well, we found one person with it. Are the siblings, or as far as if they're going to have kids, do they have a risk too? So the information is power. You need to know what's going on. And then to educate them on what to watch for. So if you're having a sudden headache that you hadn't had in the past, it's important to come to get a picture instead of waiting for a while with this headache to go away and it getting worse or causing a seizure. So education becomes a primary thing, is what do you have in your brain? What are we going to watch for? And when are we going to need to do something surgical? So having that education gives the patients power to know throughout their life what they need to watch for, having that discussion to keep them safe.
So, Dr. Melendez, I have for you one of your topic points, because I feel like this is a perfect segue into this as well, is neurogenetics, right? So this is kind of the same discussion, but taking it to your view of how that testing is done. You talked a little bit about it, touched base on it. When do you think the testing should be done within certain families, et cetera?
Yeah, I guess it depends on why you're doing the testing. Often, I think we're trying to do testing for similar things. So I think as time has gone by, we found that there's lots of genetic causes for different diseases. Genetic causes meaning there's some change in your genes that make you who you are, make your hair red or blonde or whatever. And those same changes can cause sometimes seizures, or they can cause these vascular malformations. Sometimes they cause intellectual disability, or sometimes they can cause problems with the muscles. And for a long time, we did genetic testing because often not just us, but families really wanted to know why. They want an answer. Even if it didn't change your treatment, it made people feel better to know why this happened, or it may help inform you, what to look for in the future, what your kiddo is going to look like, 15 years from now. Are they going to be independent after high school? Like, what am I going to have to worry about, progression, getting worse? So for a long time, that's why we did the neurogenetics, and that was the important piece. But over the last, I would say, decade, maybe more or less, there have been a lot of really, really amazing things that have been done in pediatric in neurology in general, but definitely in pediatric neurology, that have revolutionized what we can do for kiddos. One of the kind of most, I would say, important things that genetic testing has given us is it's helped us to make targeted therapies. So there's kind of very specific muscle diseases that many people have heard of, maybe like Duchenne's muscular dystrophy or spinal muscular atrophy. These are diseases that used to kill children, and now there's therapies that can give them essentially a normal life, or a much better quality of life.
When you say the word therapies, are you talking about medication therapies? Are you talking about physical therapies, a combination of the two?
I'm talking about gene therapies.
Gene therapies.
Yeah.
Okay. So describe what that is.
So gene therapy is basically an option for different sets of diseases where you have essentially a malfunctioning or poorly functioning, or you don't have the gene, you don't have the proteins, and it's not doing the things it's supposed to be doing for the body. So in some cases, if the gene is amenable to this, then you can basically replace it. So often, you're giving patients a lumbar puncture, where you're actually accessing the fluid around the brain and injecting like a medication. Sometimes, rarely, you can just give it in the veins, but it's pretty amazing, right? It's like science fiction, except it's now.
So how long has this been a way of treatment, this type of therapy, the neurogenetic therapy?
I mean, it's relatively new. So,
Okay.
like the first big one was for spinal muscular or I would say not the first big one, period. But in our realm of pediatric neurology, the first like real, I would say, life-changing one was probably for
Muscular dystrophy.
spinal muscular atrophy, SMA.
Okay.
And which is a childhood disease, and I want to say that was in the last decade.
Oh my.
And it's only
Okay.
recently like taken off because of access to the therapies. And then last year, actually the FDA approved a gene therapy for Duchenne's muscular dystrophy.
You said that before the show. Describe what that is.
Duchenne's muscular dystrophy.
Well, I know muscular
Yeah.
dystrophy, but
Yeah.
then this is a specific type, a branch of, or?
Yeah. So,
Okay.
there's all different kinds of muscle problems that you can have that cause weakness, that cause, worse things down the line. But Duchenne's muscular dystrophy is just a very specific type that's caused by a mutation in a specific gene, and it's almost exclusively found in boys. Because of how the genetics are passed on from generation to generation, and it's fatal. Unfortunately, you have kiddos who might be a little bit slow at when they're toddlers, and then they're able to obtain milestones, but those kind of go away rapidly. If we know, now we have a treatment for it.
And what is the demise, the atrophy itself of the muscles? Just
Yeah.
And I know I'm being physiological, but it's just, it's a blunt question, but by age, and I'm trying to think of
like what it looks like?
What it looks like, a growing child, the muscles, and it's just that the muscles don't develop? Is it that they develop and then?
So the muscle tissue is basically
Disintegrating
replaced by fatty tissue initially, and then it's the structure of the muscle itself is not well formed.
Okay.
So and then it kind of just worsens in integrity over time, and so that's why these kids are able to most of them can walk and kind of looks like they function relatively normally when they're younger, but then as time goes by, they're unable to walk. Maybe they're unable to breathe as well. They're unable to eat as well. So,
and I'm asking you this not to be icky about it, for the lack of a better word, but when you're talking about these new ways of treating, again, when we're talking about neurogenetics, 20 years ago, the picture looked a lot different, is what I'm understanding from you of how some of these treatments have come into play. And you said earlier science fiction, right? I mean, sometimes you see and you just... I talk about this when it comes to the world of research, and people often have fundraisers for different organizations that are researching. So this coming into from neurogenetics, from researching this, would you say that there's a population of 20% of children are able to now carry on and grow into a full lifetime or not? And if I'm being too difficult, we can change to a different subjects. I know we've got a lot of neuromuscular diseases that we're talking about too.
I would be hard pressed to tell you percentages on
it's a hard subject,
but because most of these are somewhat like rare conditions. Even though like muscular dystrophy is very common, it's still a rare disease. It doesn't matter if it's rare, if it's your kiddo.
Exactly. Exactly. I kind of don't know where to segue from here, but I do want to talk a little bit more about the brain and how the neurons are shooting within every sector of our body. And Dr. Makoshi, I'd like to talk a little bit more about brain surgeries now. So going back to epilepsy. And you said that there's a certain point too where if there is a refractory type of epilepsy that is not being made better by any kind of medications, where then would you as a surgeon go in and perform some kind of a surgery? What do you start looking at there in the world of epilepsy?
So that's a perfect question. Taking it back even a step before that, we know that anywhere from about 1 to 5 or 1 in 10 will have medically refractory seizures and need something more. Otherwise, they just continue to get worse. The problem is that sometimes, whether pediatricians or even neurologists are sometimes unaware or hesitant to refer to an epilepsy center, because some people either don't know that it exists or are worried that they're going to go there, they're automatically going to get surgery. They're going to cut into my child, which is not the case. The whole idea of going to an epilepsy center is getting a full workup in order to give the best recommendations to the family. This is what your child has. This is what we think the cause of the seizures. And these are the options for treatment and how they may help your child to live a better life. That's the whole idea, is to get a full assessment. So what we try and do, we have the epilepsy monitoring unit that's opened recently at El Paso Children's, which is fantastic because that's a dedicated unit where we can monitor the kids to catch enough seizures to hopefully get enough information. Dr. Melendez looks into the EEGs, interprets it for us, and tells, well, this is the abnormality. It looks like we have one area. Do we need to look at it more closely? And sometimes that's where, again, the rest of the workup with the imaging will say that in this specific area of the brain, we see some abnormality. This is the cause of the seizures. It's unclear. Sometimes we need even more workup. So we have what's called stereotactic, and that's using our little navigation system to put little electrodes into the brain. And within even less than a millimeter, actually find out exactly where that seizure is coming from.
Oh my goodness.
Now, this used to be an issue for kids that need to be referred to other centers, because you can imagine if you're a big center, you're getting referrals from all over.
Right.
The waiting list can take forever. So these families are waiting with seizures and can't get this treatment just to find out where the seizure is coming from. Are they a surgical candidate? Are they not a surgical? What's going to help my child? So we're happy to have it here so that these children don't have to travel anymore, so that we can take care of them and do this extra step if we need to, and again, get those answers.
So walk us through what this looks like. We have a child now, and you said within millimeters, how they have electrodes on their head, brains, and you're able to watch on a monitor as different things are happening. Just walk us through what that visually looks like, what you particularly are looking at.
I'm not looking at it. That would be Dr. Melendez.
Okay.
Put them in.
Dr. Melendez, what are you looking at? Okay.
The
pretty
neurosurgeons
similar.
look at it also. That's a lie.
It's pretty similar to getting a very accurate, instead of putting it on the scalp, where you can imagine if you're putting little leads on the scalp, you're kind of getting that end result as far as that electrical activity.
Okay.
If it's starting from a little area, it's already spread to a larger area by the time you catch it at the top. So if you're putting in little leads in different areas of the brain, now you can know exactly which lead it's starting from.
And you're moving them in real time.
You put them in before. So what we do is we'll plan out the areas of interest based on the first EEG, the ones that we put on the scalp, to say it looks like it's mostly coming from the right side. It's mostly coming from the frontal lobe or the temporal lobe or the parietal lobe. And then we need to put the electrodes more into these areas. So the number of electrodes that we put in, where that we put them in, depends on what we find on the imaging, what we find on those scalp EEGs. It helps guide us. Sometimes we don't know and we have to put a larger number to get more information. But usually we can identify to say it's mostly on the right, mostly on the left, and which lobe it is. And that way we put in electrodes into different areas. And those electrodes, similar to the EEG, then just have wires connected to a machine that catches the activity. It adds another benefit. Dr. Melendez can then come in as far as stimulate certain areas of the EEG and find out exactly what function that area of the brain does. So not only can we know where the seizures are coming from, is this area important for a critical function where we shouldn't remove it with surgery? Or no, is it a quote unquote silent area where if we take it out, we'll take care of the seizures and not harm the child?
So this is like a very tag team type of a situation.
Yeah.
So here's a question. We're at about 15 minutes before the end of the show, and this is where I usually stop all my questions and say, is there anything that you want to talk about this evening that we haven't yet? But what I'd like to do prior to doing that, so just think of some questions you want, some questions that you want me to ask you. Before that, however, what do you see? Like you said, a lot of the stuff with neurogenetics is a year or 2, 3 years old. What do you see 5 to 10 years from now going forward? Because I feel like there's so much that is like on the forefront of happening. What can you, to the best of your ability?
Yeah.
And your wishes, perhaps, also. Ability, but realistic wishes, best educated guesses wishes, do you see happening in the next 5 to 10 years?
I guess I'll speak to maybe general pediatric neurology and epilepsy, and then try to make it more specific to us in El Paso.
Okay.
So I think in the next few years, the hot thing that's going to continue to be big is this genetic testing, getting answers, and then at the same time as we're diagnosing what the patients have. The basic scientists and clinical scientists are working to come up with more kind of specific cures, or we would call them like precision therapy. So whether it be gene therapy or special medications that are for those particular patients, with like this particular gene that's different, or this particular epilepsy. So that field is just growing. A lot of the pharmaceutical industry and other kind of companies have really, I think, vested a lot in that, because they realize the potential and how important it is and how life-changing it can be for people, right? Like I said, kids used to die from some of these diseases, and now they can have an essentially normal life, which is
oh my gosh,
amazing to see.
Right.
So I think that's going to continue to be very important. I think specifically here in El Paso, I think that we are trying to do a lot more genetic testing, and there are certainly, I would say, sometimes it can be tricky with insurance and kind of resources, but people are working hard, I would say, to kind of surmount those obstacles. And then there's also assistance from other like kind of outside programs who understand the importance of the testing. So I think that's going to be very beneficial, because then it allows us to bring those precision therapies to the kids in the community who previously, it was limited because you didn't even know what they had.
Right.
So that's amazing. And then there's a lot of work that's being done in epilepsy surgery. There's a lot that's been done for adults, and even more in the last few years for pediatric epilepsy surgery, in particular for the use of these like devices that you can implant in the brain or in the nerves, and help seizures when you can't resect or like remove the tissue. There's a lot of data that's coming out on the utility of those devices. So I think that's going to be super exciting, and that's just like another tool that we have to help kiddos with epilepsy.
Makoshi, that's the perfect. So we're going to talk about brain implants now. Man, okay.
No, and that's a perfect discussion.
Yeah. So, we talk about, remember when the pacemaker was something, you're going to put that inside your body and it's going to monitor things, so this is not that far off from when the first person had the pacemaker that was the size of a hockey puck. But let's talk about some of these implants that help.
And they're actually similar batteries as far as
well, there you go.
that need to be replaced every few years. And they're working on that too, to find rechargeable batteries as well, instead of having to do surgery 5-10 years down the road. So there's a lot, again, work in progress for the implants to stay implanted and not need to be revised and having another surgery. We're still a little time away from that, but I'm hoping soon that it is rechargeable and we don't have to do surgeries. But there's different type of implants. There is one of the oldest ones we talked about was the vagus nerve stimulators, which is kind of the catch-all for all epilepsies that may not be responding to medications. So it's little incision in the neck and electrodes that sit on one of the biggest nerves in the body, the vagus nerve, and then a battery that's implanted into the chest. And there are smaller batteries nowadays, and they keep getting smaller and smaller, which is nicer for the younger kids. And what it does is it gives, as far as these stimulations, to interrupt the pathways and thereby stop seizures or decrease the frequency or the severity of the seizure. They've gone even more advanced, where if you notice that your child is having a seizure, you have a little magnet, and you can give an extra boost to stop the seizure. So a lot of these changes have happened over the few years, and we're just getting smarter and smarter to treat it better and better.
What I'm going to do is stop you just for a second, because this is so important. I think that we kind of got to it late last time. Explain what the vagus nerve does. Why is that the important nerve? And then I'd like to continue with this discussion, because I feel like if we don't understand what that is, then it's hard to understand why it's implanted by the vagus nerve.
The vagus nerve is one of the biggest nerves in the body that connects with multiple things below the neck, where the majority of the cranial nerves, the ones from the brain, sit inside the head. Not only that, it has the most relay of any of the other nerve, where it's connected to so many different pathways. So it seems to be, both in location and how many connections it has, a perfect target. If you're going to try and neuromodulate the brain to change it, that's the one to aim for. And that's what they tried, and it seemed to work out. There's still theories as to why it works, and we're getting better to understanding it, but we don't know for sure aside from it has so many connections, and that may be why. And the vagus nerve stimulators are one of the few things that if you have a good response after a few months, your response is actually better at a year, 2 years, and 5 years. So you get even better benefit over time. So it's one of those things that over time you can show more improvement. So that's the beauty of as far as using the vagus nerve, and one of the benefits of if you're stuck against a wall with medications, there are sometimes options that may help your child. And that's important to know.
So I know vagus nerve. I'm that person that has her blood drawn and likes to faint. And I remember somebody said, well, that's a vasovagal thing. I'm like, what? And that's the first time I heard about the vagus nerve. And I didn't understand it. I still honestly don't quite understand it, but it also fascinates me that this is the nerve that affects so many different things. In your experience, Dr. Melendez, we talked a lot about the brain, but we're kind of just getting to the vasal nerve right now. When parents come to you, and there are questions, again, I feel like I'm going back to the beginning of the program, but when parents come to you and say, I'm noticing that there are, either 30 seconds, a minute or two, my child is just clocking out. And again, it's going back to the beginning, but what is it from there that you have the discussion with the parents? Like what leads you to that first test, if you will, to find out what's happening?
I mean, really listening to the parents and taking a good history, which is, basically just knowing what questions to ask. And again, I'll say it again, like listening to what your families say, right. Because, often like they're your kids, right? So you notice you notice everything. So depending on what the parents say, like your example of staring off, a common kind of seizure type that we see in kids is what's called absence seizures. So those are like the mini kind of seizures where you just stare off for a little bit and then you're okay and last a few seconds. And those have kind of very different treatments and very different causes of them or etiologies as someone who's staring for, say, like a minute or two, which in that case, I would start wondering whether they actually had like a temporal lobe epilepsy, which is very different from these absence kind of seizures and the associated epilepsies. And so really it's asking the history.
Asking the history.
Yeah.
And if they are relatively short-lived, so I feel like, with my son again, there were seconds at a time. You just think that we didn't know what to look for, what to ask for until he actually fell down in the shower. It was one of those things that we just like, and again, well, I had a zappy. It's like, what do you mean you had a zappy? He's a full-on teenager at this time. He's older now. But, and I'm saying that for people to ask for some help if they can. And maybe there's a website out there. I don't ever encourage people to do Dr. Google because you can get scary and you go down the rabbit hole that you don't want to go to. But again, if you're watching this right now, feel free to call the El Paso County Medical Society or info at the El Paso County Medical Society and ask your question. And we'll make sure that a medical person gets back to you with that. On that note, I would love to maybe open it up to something that you wanted to talk about this evening and we didn't quite get to, or something you'd like to talk a little bit more about. And the veteran always gets to go first since you've been here once before. What is it that you'd like to talk about this evening that we may not have touched base on?
I think the only thing actually is mostly just to reinforce.
Okay.
Because we know that a large number of people just aren't coming to see us.
Yes, and that's kind of that point of when do they do that?
Exactly. And what's been shown is that even the kids that are referred to epilepsy centers for assessment and management that don't end up getting surgery still do better than those that haven't been referred for epilepsy assessment. So just because you're coming to see as far as an epilepsy neurologist and an epilepsy neurosurgeon doesn't mean that surgery is going to be the right thing. Sometimes it is. Sometimes it's the best option for your child. Sometimes it's not. But knowing that and knowing what to change, whether with medications, with regimens, what to watch out for, just that education from getting that full assessment, including your child has issues with memory specifically, so they may benefit from taking more time with this. With language, for example, so they may need to pay attention to this. So just getting that full assessment is useful to parents. So it's important if you think your child has epilepsy or they do have epilepsy to get assessed, and you don't need to travel to as far as big centers, because we were trained at big centers and came here to offer that to the patients.
So I'm going to throw this out as a plug, but it would be the Regional Pediatric Epilepsy Monitoring Unit. So let's just say somebody is listening and they're like, oh, who do I call? El Paso Children's Hospital. And then again, that is where something you can put into the search engine. If you have a phone number, great. I didn't ask you ahead of time, so of course you're not prepared, because all of us just have everything on the phone. But again, it's called the Regional Pediatric Epilepsy Monitoring Unit, and that is where the magic happens, where you try to figure out what is happening, going on. And again, the monitoring is great. Anything that we haven't talked about on your plate, Dr. Melendez? I know we covered a lot. It's an awful lot that we have, and I almost want to cry when you were talking earlier. But you're right. I mean, things are very rare until it's your person. If it's your child, then it's not rare at all. It's what you deal with all day, every day.
Yeah.
Is there anything we haven't touched base yet that you'd like to talk about?
No, I guess Dr. Makoshi had I second everything that he said. But I'm very excited for everything that they're doing at El Paso Children's, and hopefully everything that we're trying to build. Because it stinks to have to leave to go out of town. It stinks to leave your family, your other kids, your job that is giving you your insurance to pay for these things.
Right.
And I think that we as definitely as a team, and with the rest of the Children's Hospital and members of UMC and Texas Tech, like Dr. O'Neill, like Dr. Lopez, I think that we're building something where we're really going to be able to help the kids within this, not just El Paso, within the region, and something that will last.
There are 3 different places that you can go to watch us again. One is pbselpaso.org, and you would find the El Paso Physician on that website, and you can go there and you can see this as well as other shows that have been aired. Also, the El Paso County Medical Society, which is EPCMS. Just think about that acronym again, EPCMS, El Paso County Medical Society, and that's a .com. And then also YouTube, you can almost find anything and everything on YouTube. It's a little scary. So I thank you so much for being here, Dr. Melendez and Dr. Makoshi. I just like saying your name, Dr. Makoshi.
Thank you so much.
And again, anytime I watch some kind of a show and they're operating on the brain and somebody's lifting up, I will tell you, I think about you every single time. But Pediatric Neurosciences in the Borderland was our topic this evening. Thank you so much for joining us. I'm Catherine Berg, and this has been the El Paso Physician.
Good evening. I am Dr. Allison Days, a past president of the El Paso County Medical Society. The El Paso County Medical Society has put on the El Paso Physician TV program for the last 26 years. These programs are archived on kcostv.org, epcms.com, and on YouTube. You may access the programs at any time on these websites. If you have questions on tonight's topic, please reach out to epmedsoc@aol.com, and we will try to get your questions answered in a timely manner by an expert in the field. Thank you again for tuning into the El Paso Physician tonight.